Future nurses, I am thrilled to present this unfolding case study crafted specifically for NCLEX RN preparation to challenge and sharpen your clinical judgment skills. And I will guide you in applying critical thinking to real-world nursing scenarios in our Next Generation NCLEX test items.
Before moving ahead, here's something you need to hear. If you're feeling anxious about passing the NCLEX, especially if you're aiming to do it in 1 week or 1 month, then our complete online NCLEX review crash course is your answer. This is your shortcut to success, a tried and tested course with a 99% passing rate. More than 5,000 students have achieved their NCLEX goals using this course, and now it's your turn. Here's what's included. 100-hour animated mini crash course, perfect for last-minute preparation to pass in just 1 week. 300-hour comprehensive lectures covering 300 high-yield topics that the NCLEX loves to test. 5,000 real NCLEX questions. Train with real exam-style questions and be prepared for anything. 15 full-length practice tests, including CAT simulation. Build your confidence with realistic exam experiences. Exclusive NCLEX ebook and 1-year access. Study whenever you need without restrictions. Don't let this opportunity slip away. Enroll now at 70% off. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. Now, let's jump into the topic.
Let's begin. So here's our first item. We have a bow tie, and this case scenario is about a 76-year-old female admitted to the orthopedic unit. So we are reading here the history and physical. Of course, we're still on page 1 right now. And the chief complaint for this patient is right hip pain and inability to bear weight after a fall. And the history included that the patient slipped on an icy driveway while retrieving mail, experiencing immediate right hip pain and a popping sensation. She denies head trauma, but reports lightheadedness prior to the fall and able to ambulate post-fall, prompting emergency department visit. Her medical history includes osteoporosis, being treated with alendronate sodium, atrial fibrillation, taking warfarin. She has mild cognitive impairment, mini mental state examination score at 24/30. And the medications she currently takes are alendronate sodium 70 milligrams PO weekly and warfarin. The dose is not specified for atrial fibrillation. And she is allergic to sulfa drugs. She lives alone in a single-story home with cluttered layout. She uses a walker due to prior falls. Limited social support. She relies on neighbors for groceries and expresses fear of surgery and losing autonomy, stating, "I don't want to be a burden in a nursing home." Let's take a look into our next section of our medical history. We have the review of systems. For the musculoskeletal system, it said severe right hip pain, inability to bear weight. She has lightheadedness prior to fall, no loss of consciousness, mild cognitive impairment noted. She's anxious about surgery and future independence, negative for head trauma, chest pain, or shortness of breath. In her physical examination, she is alert, anxious, cooperative. Her right leg is shortened, externally rotated, tender over proximal femur, ecchymosis are noted, and there's distal pulses and sensation intact, not explicitly stated, but implied by lack of contrary findings. There's that MMSE score again, 24/30, and for the diagnostic studies, it showed in the right hip x-ray, extracapsular trochanteric fracture of the right hip. And the initial diagnosis is right extracapsular trochanteric hip fracture. And the plan is to admit to orthopedic unit, apply box traction preoperatively, schedule open reduction and internal fixation with dynamic hip screw for day 2. Hold warfarin and bridge with enoxaparin. Consult social work for discharge planning. Now let's get into our vital signs. We have a trend of vital signs here from day 1 post-op, day 3 up until day 5 for the temperature pulse rate. respiratory rate, blood pressure, oxygen saturation, and pain score. So I want you to scan on all these findings and values before you head into answering the question. Now, what else do we have? We have the following healthcare provider orders. For the medication, the prescriptions are enoxaparin 40 milligrams subcutaneously daily, hydromorphone 0.5 milligram IV every 4 hours is needed for pain, acetaminophen 650 milligrams PO every 6 hours, alendronate sodium 70 milligrams PO weekly, and metoprolol 25 milligrams per orum twice a day. And the diagnostics ordered were X-ray of the right hip and the femur, complete blood count, comprehensive metabolic panel, international normalized ratio, and activated partial thromboplastin time. Now, there's also consultations in place for orthopedic surgery for the ORIF procedure and social work for the patient's home safety, and box traction pre-op and home safety assessment post-discharge. Now, let's take a look into the laboratory tests and diagnostic tests. We have values of hemoglobin, white blood cell count, platelets, creatinine, INR, activated partial thromboplastin time, C-reactive protein for days 1, 3, and 5. I want you to scan, make sure that you capture those needed information. And of course, we got the diagnostic tests. We have the right hip X-ray done on day 1st, and right hip X-ray done as a follow-up on the 3rd day, and right leg ultrasound done on day 5, and ECG on day 1, showing atrial fibrillation controlled rate. Are you ready to answer the bow tie question? And as usual, this is all going to compose of the 5 boxes. You got the potential condition, 2 nursing actions, and 2 parameters to monitor that you need to supplement. Now, for this test item, I want you to look for the diagnostic results in day 5 data to pinpoint the patient's condition, and I want you to consider how day 5 orders guide the treatment actions. And also, monitoring should also focus on both the condition's progression and the treatment safety. Don't make that error. Now, we have the following options for the potential condition. It says venous insufficiency with inflammatory edema, postoperative hematoma with secondary infection, deep vein thrombosis with systemic inflammatory response, early surgical site infection with soft tissue extension, subclinical periprosthetic fracture with reactive inflammation. Now, what do you think would be the best answer here? Now, the answer here is DVT with systemic inflammatory response. I want you to go back in the patient's chart that on day 5, she is showing several concerning signs. One of those is the new right thigh pain. She rated that as 7 out of 10. There's swelling warmth and also low-grade fever. Take note about the temperature of 100.3 degrees Fahrenheit. And the white blood cell count, the C-reactive protein were elevated. And when you're going to put all these together, especially when we see that this was already confirmed, there was that ultrasound confirming that there is DVT in the femoral vein, then it becomes clear we're dealing with more than just a localized clot. Now, at this point, her body is mounting a systemic inflammatory response, which is not uncommon in post-op patients who develop significant DVTs. And the context is important here too. She just had orthopedic surgery. She's relatively immobile. She has atrial fibrillation, and she was recently bridged from warfarin to enoxaparin. She has all the ingredients to develop the DVT. All right, I want you to remember about the Virchow's triad. Now, all of these increase her risk for thrombosis and complications. So while this might first present like a straightforward DVT, the presence of the systemic symptoms pushes it into a more complex clinical picture here, one that needs close monitoring and immediate action. Now, let's take a look into the other options that are incorrect. If you selected early surgical site infection with soft tissue, secondary, it said postoperative, let's take a look into here. Early surgical site infection with soft tissue extension. This might catch your attention because of the fever and the leukocytosis, but there's a key difference here. There's no mention of wound drainage. There's no mention of redness at this point, especially at the surgical site, or there's no mention of other signs pointing to an infection around the hardware. Now, also, the DVT is already confirmed, and that's a more likely cause for the symptoms at this point in her course. Now, let's look into the other options. We have subclinical periprosthetic fracture with reactive inflammation. We know that the patient does have an osteoporosis. If you want to go back into our history and physical, which could have predisposed her to further fractures. But the x-rays show intact hardware, and there's nothing pointing to a new break or a mechanical failure. Plus, the DVT is already confirmed, so there's no need for you to go looking for a different structure or cause. Now, if you selected postoperative hematoma with a secondary infection, this is incorrect, because with hematoma, this could cause swelling and discomfort, sure, but there's no documentation of a visible or palpable mass. And again, we already know that this is confirmed by the ultrasound. Now, if you're going to jump to infected hematoma, it would be skipping over the clear diagnosis, so disregard this one. Now, if you selected venous insufficiency with inflammatory edema, this tends to be a chronic issue. It's not something that comes on acutely like this. And it also would not explain the elevated inflammatory markers such as the CRP or systemic fever. And this isn't the right clinical picture for that. Now, pay attention to the two nursing action boxes. So I hope that you have finalized your answers here. And the options are the following: elevate right leg with graduated compression, consult vascular surgery for DVT management, apply cold compress to reduce swelling, titrate heparin infusion to therapeutic activated partial thromboplastin time, initiate broad spectrum IV antibiotics, obtain an order for CT of the pelvis. So first of the two nursing actions that you should select is titrate heparin infusion to therapeutic APTT. We know that the DVT has already been confirmed, so our focus will shift to preventing progression or preventing the growth of the blood clot. So we don't want to cause embolization. That's our main goal here. Now, if you administer the heparin, especially we're talking about an infusion here that we can titrate. So this is going to ensure that we are going to achieve the anticoagulation level without overshooting and risking bleeding. And if you want to go back into the lab value, especially on day 5, which is 60 seconds, so pay attention to the APTT. So that's basically within a typical therapeutic range. So that's a good sign. Now, if you selected elevate right leg with graduated compression, now this is very important. This is a key non-pharmacologic measure that you can do to help reduce swelling and also promote venous return. Now, very important that you should avoid things like applying massage to the affected area or application of heat, which could actually increase the risk of dislodging that clot. Now, let's pay attention to the incorrect options. So one of those is initiate broad spectrum IV antibiotics. This is quite tempting, right? But when you go back into the laboratory, there's no confirmed infection yet. And if you're going to start the antibiotics too early, especially without a clear source, this can lead to resistance and unnecessary side effects. That's why we're not going to select that one. Now, if you selected obtain an order for CAT scan of the pelvis, now, why is this incorrect? This might be useful if the x-ray were inconclusive or if we had strong signs of hardware failure, but we don't. And the x-ray shows the hardware is intact and the pain is in the thigh, not at the surgical site. That's why we are not selecting this. Now, if you selected apply cold compress to reduce swelling, another incorrect option, because cold may reduce superficial swelling, but it's not a primary treatment for DVT. It's not really targeting of what we need in this case. Now, what we intend to do is to actually elevate that affected extremity and apply the compression, especially graduated compression, which is much more appropriate and based on evidenced and applicable studies. Now, if you selected consult vascular surgery for DVT management, this might seem helpful, but for a standard post-operative DVT, vascular surgery typically is not needed unless there are complications or contraindications to the therapy. And this isn't one of those cases. Now, let's shift into the two boxes for the parameters to monitor. We have the options, thigh circumference and skin warmth, inflammatory markers. We're talking about the C-reactive protein and the erythrocyte sedimentation rate, activated partial thromboplastin time and signs of bleeding, wound drainage and erythema, respiratory rate and oxygen saturation, and distal pulses and sensation in right leg. So I hope that you've made up your mind in selecting those two parameters. One of the answers is thigh circumference and skin warmth. This give you real-time bedside indicators of how the DVT is progressing, because increased circumference or increased warmth might signal worsening clot burden or increasing inflammation, which you'd really want to monitor early. Now, the other intervention, or parameter, I should say, is the activated partial thromboplastin time and signs of bleeding, because she is on the heparin infusion, and this is non-negotiable. And I want you to remember that the APTT will help us in the dosing, the titration, and also because she just had the surgery and already has a declining hemoglobin. Remember that. I want you to pay attention into the hemoglobin levels from day 1 up until day 5. That's quite significant, right? So you need to be on alert for any signs of bleeding here, especially at the surgical site. Now, the rest of the options are incorrect. So if you selected wound drainage and erythema, these would be appropriate if we're monitoring for infection at the incision site, but that's not the main issue here. Now, if you selected distal pulses and sensation, these are important in cases of arterial compromise or if the patient may have compartment syndrome, but not typically affected in deep vein thrombosis unless things become more severe. That's why you got to eliminate this. If you selected inflammatory markers, CRP, ESR, we know that the CRP is already elevated, so it confirms inflammation. So from day 1, it was 5 milligrams per liter. It went up to 10 milligrams per liter on day 3 and 25 milligrams per liter on day 5. But it's not going to guide your minute-to-minute decisions. It's not really going to help in determining the interventions that you had selected are effective, right? It's not really going to correlate with that. So this is more of a supporting clue than something that you should monitor continuously. So disregard this one. Now, if you selected respiratory rate and oxygen saturation, these are essential if we suspect pulmonary embolism. But right now, this is still a localized deep vein thrombosis. The patient is not manifesting any of those pulmonary embolism signs and symptoms. And her oxygen saturation is borderline at 93%. There's no complaint of chest pain, no shortness of breath. So would keep an eye on the DVT right now. So I hope that you're able to tackle all those distractors and discard them. Now let's move on into our next test item. We have a hotspot highlight. It says here, the nurse reviews the admission assessments to identify risk factors for postoperative complications post-ORIF. Now, your task is to highlight the findings requiring immediate follow-up. So my hint for you in answering this question, go back and focus on the patient's medical history and assessment data that signal increased risk for surgical or recovery issues. And I want you to consider social and clinical factors that also affect safety after the discharge is initiated. Now, we have the following categories here: the past medical history, social history, initial assessment, and the details included osteoporosis, atrial fibrillation, mild cognitive impairment, lives alone in a cluttered single-story home, uses a walker, limited social support, and steady gait, hemoglobin 11.5 grams per deciliter, INR 2.3, C-reactive protein 5 milligrams per liter. Lung sounds clear. Now, I want you to pay attention. We're actually highlighting those findings requiring immediate follow-up. Now, what do you think would be one of those? Well, we have osteoporosis, right? This is not just a chronic condition in this patient. It directly impacts her surgical recovery. We know that osteoporosis makes the bones fragile, and after a repair or like after an ORIF, there's a real concern about the hardware failing or the bone refracturing around it. So this is not just about the background information or historical data of this patient. This is a red flag for possible mechanical complications after the procedure. Now, what else do we need to highlight? There is the atrial fibrillation. Now, why do you think atrial fibrillation is something that you need to follow up? This is a no-brainer finding. She is anticoagulated going into surgery, and her INR is elevated at 2.3. Now, bleeding risk is a major issue post-operatively, and the healthcare team already had to hold warfarin and bridge with enoxaparin. So it's a balancing act, preventing clots, but you don't want to cause unnecessary bleeding at the same time. And that's why we are including AFib right now. Now, what else do we need to highlight here? We have mild cognitive impairment with a score of 24/30 on her MMSE. So this score alone is basically telling us that she has mild cognitive decline. And that alone may not seem urgent right now, but we have to connect the dots. She's just had surgery. She is in a strange environment, and she's now at a high risk for delirium. This is a big deal. This is something that we need to keep an eye on. Patients, especially elderly people, once they are admitted in the acute care setting. That's a big red flag. Now, we have to identify this early in order to prevent any of these complications, and so that we can devise some strategies, let's say maybe quiet room, making sure that we are reorienting the patient, and possibly early mobilization to prevent those complications. Now, what else we need to highlight here? This is we have lives alone in a cluttered single-story home. This social detail has clinical consequences. This is very important. And the discharge planning is going to be tricky here because the patient is a fall risk at home already. She had a fall and she had poor support system, and the home environment that is not safe. It said that her home setting is cluttered. So these can derail her recovery unless these are all addressed early on. Now, what else do we need to highlight? There's that unsteady gait, which is a key factor in the fall that led to her injury. And if we are not going to correct this, or if we're not going to support this after the surgery, she's a high fall risk again. So we need physical therapy, fall precautions, and possibly mobility device review. So pay attention to that. Now, what else do we need to highlight? We have to highlight hemoglobin 11.5 grams per deciliter. You might think that this is just borderline, but consider the whole picture. She is elderly. She's recently injured, and she's about to undergo surgery with an elevated INR. So even small drops post-operatively, this could tip her into symptomatic anemia. So yes, this number matters here. Now, the other findings are not supposed to be highlighted. So if you selected clear lung sounds, well, there's no problem in that. So that's not going to pose a concern. Now, if you selected CRP 5 milligrams per liter, that's slightly elevated, but not alarming at this stage. And CRP trends are more helpful later when we are watching the patient for other complications. Now let's go into our next test item.
Before moving ahead, I have some exciting news for you. If you are determined to pass the NCLEX within a week or a month, then your best option is to enroll in our complete online NCLEX review crash course right now. This course is a comprehensive all-in-one solution, a guaranteed shortcut, and a proven method to pass. Over the last 5 years, more than 5,000 students have successfully cleared their NCLEX exams using this course with an impressive 99% passing rate. Here's what you'll get: 100-hour animated mini crash course, ideal for those who have limited time and want to pass in just 1 week. 300-hour comprehensive recorded lectures covering 300 high-yield NCLEX topics that the exam loves to test. 5,000 real NCLEX questions, practice with actual past exam questions for better preparation. 15 full-length practice tests, including CAT simulation. Feel confident before your real exam day. Exclusive NCLEX ebook, the ultimate guide you need to pass. 1 year full access. Study anytime, anywhere at your own pace. This is a limited time offer. Enroll now to grab 70% off. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. All right, now let's dive into the topic.
This is a multiple response grouping test type. Now, the scenario says, on day 3, the nurse plans interventions for delirium and pain control post-ORIF. Now, let's scan through all the notes here. On day 3 at 8 o'clock, surgical site pain is rated at 6 out of 10. Delirious, disoriented to place, pooling at IV lines, temperature 99.7 degrees Fahrenheit. TEDs and SCDs applied. Physical therapy is limited by confusion and pain. Haloperidol 0.5 milligram IM given. Geriatrics consulted. Now we also have the vital signs, comparing the vital signs on day 1 and day 3. And we have some healthcare provider orders. Medications such as hydromorphone, 0.5 milligram IV every 4 hours as needed for pain. Haloperidol, 0.5 milligrams IM every 8 hours as needed for delirium. And others, we got TEDs and SCDs post-op. PTOT for mobility and home safety assessment. Now, what do you think you should be doing here? Now, your task is to select the interventions in each category based on their primary purpose. Here we have our matrix. Now, before you select the answers here, I want you to pay attention to the clues. Now, we are actually focusing on day 3. So pay attention to the progress notes for symptoms, which will help in guiding you the interventions, and make sure that you review the healthcare provider orders and to identify the prescribed actions and make sure that the interventions will fit into that specific category, right? So here are the following. We have the category: delirium management, pain control, complication prevention, and discharge planning. Now, for the delirium management, what we're going to do here is to focus on the interventions that directly target acute confusion, directly targeting agitation and the risk for harm due to the mental status changes. So the correct answers here are the following. One is to administer haloperidol 0.5 milligram IM. So this patient is showing hyperactive delirium. She's pulling at IV lines, she's disoriented, and she's at risk for self-injury. Now, going back into the medication, Haldol or haloperidol, this is an antipsychotic drug. And remember that our patient is elderly. Now, for this scenario, you have to be careful because this medication can cause some side effects or adverse reactions. It can cause anticholinergic effects. Now, I want you to consider the dose that you are giving to this patient. But at this point, the dose seems safe on the cardiovascular system, especially that the patient has a history of atrial fibrillation. And I want you to pay attention, guys. We don't give IV haloperidol in a patient, especially if they're not on cardiac monitoring, continuous cardiac monitoring, because it can cause prolongation of the QT interval. So that's why this is a safe intervention here. This is given as intramuscular injection, right? So I hope that you will remember this. Now, this intervention seems simple, but it is a mainstay in delirium care. We have to provide gentle, repeated reorientation, which will help the patient reestablish a sense of reality and also to reduce their confusion. And you might do this with a calendar. Maybe you're going to provide a clock in the patient's room, and you have to provide regular check-ins, or even by saying, you're in the hospital recovering from the surgery. So small things can actually make big differences here, especially for this patient having delirium. Now, another correct answer here is to consult or reorient patient to time and place. Now, what do you think? Why do you think that this is correct? Well, when you are reorienting them, well, this actually can reestablish a sense of reality. And the next thing that you should be doing is to consult geriatrics for delirium. This is huge because of her age and also the MMSE score. And now, after the surgery, she's developing delirium. So geriatrics should absolutely be involved in the care. So with that, they can help adjust the medications, they can assess for polypharmacy, and they can also implement delirium protocols. So this consultation will help improve outcomes, and the NCLEX really like to ask this type of question because this is in some form of a multidisciplinary coordination. So I hope that you're getting this. Now, another intervention that you should select is minimize environmental stimuli, because delirium is often worsened by overstimulation. We're talking about bright lights, constant noise, too many people coming in and out of the patient's room. And here we're gonna provide dimming of the lights, keeping the room quiet, and providing rest periods. And we have to provide high impact strategies that will help the patient settle their mind. Now, why not administer hydromorphone 0.5 milligram IV? Why is this not fitting to the delirium management? Well, this is what we want for pain management, all right? And let's be clear here. Pain can actually contribute to delirium, but the opioid, which is the hydromorphone, do not treat delirium And in fact, this can sometimes worsen the delirium if we are not being careful, especially in older adults. So when you are administering opioid type of pain meds, such as hydromorphone, you have to be careful, make sure that you are assessing the patient. If they're dealing with the meds, if they're able to tolerate the medication, because this can cause undue sedation, this can worsen their disorientation, and this can also increase their fall risk. So while pain should be addressed, giving the opioid doesn't belong under the delirium management. So this is a critical distinction for the NCLEX. You got to treat the root cause with appropriate strategies, not just about the symptoms. Now let's go into the pain control category. What do you think? Before we go do that, there's actually applied TEDs and SEDs. Why do you think that this is incorrect for that category? Well, these are effective strategies for DVT prevention, but these do not treat delirium. Okay, these two, TEDs and SEDs, would not calm the patient. It would not improve the orientation, or it will not reduce the agitation. Now, finally, we're going to proceed to the pain control category. So what do you need to do here? We are going to shift to comfort measures. Take note that the patient is post-op with a surgical site pain score of 6 out of 10. So your goal is to manage that pain enough for her to participate in physical therapy and to avoid complications from immobility. So the correct answers here would be administer hydromorphone 0.5 milligram IV. This is the direct pharmacologic intervention for pain relief. And the pain is at the surgical site, and it's enough to impact function. And take note that in controlled doses, the IV hydromorphone can significantly reduce pain, and it can make the patient more cooperative with therapy, positioning, and this will also ease in their process of doing the deep breathing exercises. Now, don't forget that when you're administering an opioid medication, always assess respiratory status before and after, because this medication can cause respiratory depression. So the rest of the answers here or options are incorrect. So if you selected administer haloperidol 0.5 milligram IM, this is to treat delirium. If you're giving this drug under the pain control category, this will not reduce the patient's pain. It will help the patient calm down, but it will not help the patient feel more comfortable. All right. Now, if you selected reorient patient to time and place, this is not really correlating to that. This is a nursing task that you can do to help the delirium. It's not about pain intervention. Now, what about monitor the surgical site for infection? This is an important nursing task, but this is more about prevention and early detection of complication. This one doesn't relieve pain. Now, if you selected encourage incentive spirometry, this is also an important task, but this is intended for respiratory support to prevent atelectasis. It will not prevent pain, or it will not treat the pain. Now, what about coordinate home safety assessment? This is something that you should consider doing when you are concerned about discharge planning, especially for someone who's living alone in a cluttered home. But this task right now doesn't belong in this category. Now, moving into the next category of complication prevention. So one of the answers here is apply TEDs and SCDs, because our patient right now is post-surgical, they're immobile, and they are high risk for developing the blood clots. And take note that she has a history of atrial fibrillation, a recent fracture and surgery, and take note that the TEDs and the SCDs. So if you are not familiar what an SCDs are, this is sequential compression device, and this is, apply kind of sort of massages into the unaffected extremity, right? To keep the circulation going, to prevent stagnation of blood flow. Now, what else do we need to select as appropriate nursing action here. We are going to educate on hip precaution. We want to prevent hip dislocation, which is a real risk after the ORIF. And so we are going to teach the patient on how to sit, to stand, and move safely. Make sure that you include in the teaching no crossing of legs, avoiding bending over 90 degrees. These are important teaching points. Now, another nursing task that you should select is to monitor surgical site for infection, because our patient is running low-grade fever after the surgery. So this could indicate early infection, and we have to monitor for any signs of infection such as redness. If there's going to be drainage or tenderness at the surgical site, we need to investigate further if these things set in. So make sure that you regularly check all these things in that operative site. Now, what else do we need to do? We are going to encourage incentive spirometry. This is your frontline defense against post-op pneumonia, especially in the older patient who are more spending time in bed. And this is to keep their lungs expanded, to prevent hypoventilation, to prevent atelectasis, and to prevent infection, especially lung infection. Now, the rest of the options, such as reorient patient to time and place, this doesn't fit here. This is something that you should be doing for delirium management. So this is basically a mislabeling. And if you selected consult geriatrics for delirium, this is a useful action, but it's not a direct intervention to prevent complications like infections or blood clots. All right. Now, last category, we have discharge planning. What do you think would be the aim here? So your focus in this category is about safe transition to their home setting, or possibly discharge, right? So this is something that can begin early in the hospitalization and very critical for someone who lives alone and who has very limited social support, and she's also a high fall risk. So the correct answers that we have are the following. Coordinate home safety assessment. We know that she lives alone in a cluttered home environment and also uses a walker. So before the discharge, we need to ensure that her environment won't set her up for another fall. We are going to arrange and make sure that the healthcare provider orders occupational therapy or possibly physical therapy or maybe social work to collaborate on this one. Now, if you selected consult social work for family support, this is also a good action because she doesn't have a strong support system and she is worried about being a burden. And we know that social work can help plan for services like home health, meals on wheels, or even transitional rehab if needed. So the rest of the nursing actions here are not really matching into this category. Again, administering hydromorphone belongs to pain control category. If you selected administering haloperidol 0.5 milligram IV, this belongs to delirium management. If you selected about educate on hip precautions, this one feels tricky, right? It's important, but it belongs to the complication prevention. Now, lastly, we have minimize environmental stimuli. This is another great strategy for delirium, but this is about hospital care, not discharge planning, and that's why we're gonna leave that box empty right now. So I want you to reflect on what you have selected as far as the answers for these matrix. All right, guys, let's move on to our next test item. We have a drag and drop rational item, and it says here on day 5, the nurse addresses the patient's refusal of physical therapy due to fear of re-injury and thigh pain from a confirmed deep vein thrombosis post-ORIF. It says in the nurse's progress notes, dated day 5, 7 in the morning. New right thigh pain, 7 out of 10. Swelling, warmth, temperature 100.3 degrees Fahrenheit. Oxygen saturation 93% on 2 liters nasal cannula. Right thigh erythematous tender. Confirmed DVT via ultrasound. Suspected infection or hardware issue. Refuses physical therapy, stating, "I'll break my hip again." Disoriented to time and person. Agitated, attempting to climb out of bed. Haloperidol 0.5 milligram IM administered. Orthopedic and infectious disease notified. Enoxaparin continued. Immobility noted as DVT risk. Now, I want you to scan into the parameters here for the vital signs from day 1, day 3, day 5. So we got everything for the temperature, heart rate, respiratory rate, the blood pressure, oxygen saturation, and pain score. Now, your task in this test item is to drag and drop the interventions into the correct order of priority. Now, the options, before we're going to go to the options, the healthcare provider orders are the following. Hydromorphone 0.5 milligram IV every 4 hours as needed for pain. Heparin infusion. A patient is currently in the therapeutic range. And there's an order for physical therapy, occupational therapy for mobility. Now this time, we have the result on the right leg ultrasound confirming that the patient has right femoral vein DVT. Here are the nursing intervention options. The first one we have is measure thigh circumference to monitor DVT progression. Refer to physical therapy for a modified mobility plan. Administer hydromorphone 0.5 milligram IV for pain relief. Use therapeutic communication to explore fear of re-injury. Administer haloperidol 0.5 milligram IM to reduce agitation. And titrate infusion to therapeutic activated partial thromboplastin time. Now, in this test item, I want you to look for the patient statements. So this time I want you to go back into the nurse's progress notes on day 5 to understand refusal reasons. And I want you to consider how the symptoms and orders can influence the intervention priority. And the top intervention should target the root cause of non-participation. So I want you to arrange the nursing interventions according to the priority. Now, what do you think would rank the first priority here? The answer is, of course, use therapeutic communication to explore fear of re-injury. And why do you think this one comes first? Well, this is the root cause of the issue. The patient is not just refusing physical therapy because of pain or confusion. She verbalized a clear fear. She said, "I'll break my hip again." And take note that fear is a psychological barrier that needs to be acknowledged and also addressed by the nurse before anything else will work. Now, if you're going to skip this step, the pain medications won't help, the haloperidol won't help, and physical therapy certainly won't get far. So make sure that you do this as your priority option. You need to build trust and help her feel safe first. Otherwise, everything else is just noise. Pay attention to that. Now, the next one, the second priority is to administer hydromorphone 0.5 milligram IV for pain relief. And why do you think this goes into the second spot? Now, go back into the assessment finding. Her thigh pain is real. 7 out of 10. It's from a confirmed DVT and also the surgical site, which is both painful and frightening. Now, even if you address her fear, she's not going to cooperate with physical therapy until that pain is managed. Now, it's very important that you're administering the hydromorphone. It shows that you're actually concerned, you're addressing her discomfort, which helps reinforce the trust, and physically it's going to prepare her to move during the physical therapy. Now, the third rank here should be administer haloperidol half a milligram IM to reduce agitation because her delirium is escalating. She's disoriented to time and person, and she's trying to get out of bed, and this is a safety issue. Now, I want you to recall that haloperidol helps calm hyperactive delirium so she can follow directions and remain safe. This is very important, but it won't address her physical therapy refusal unless fear and pain are handled first. So this is going to be our third rank. Now, the fourth rank should be titrate heparin infusion to therapeutic activated partial thromboplastin time. And why do you think that this is kind of lower into the rank? Yes, we know that this is critical for DVT management, but it doesn't directly impact her refusal to engage therapy. This is the main issue. And that said, it's still essential in preventing pulmonary embolism or clot extension, and it must be adjusted based on the APTT results. So here, you're not ignoring this, you're just sequencing it appropriately. Now, the fifth should be referred to physical therapy for a modified mobility plan. Why do you think that this is on the fifth? Now, once the fear is addressed, the pain is addressed, and the confusion have been managed, the team can return to physical therapy and customize a plan that feels safer for this patient. Maybe she uses a walker instead of trying the stairs, or they begin with bed exercises. But physical therapy won't work until she's mentally and physically ready. And lastly, this sixth place should belong, that would be measure thigh circumference to monitor DVT progression. And why do you think that we're putting this as a last priority? We know that this is part of the ongoing assessment. It's not a direct intervention for physical therapy refusal. Now, take note that measuring swelling can help monitor whether the clot is resolving or worsening, but it doesn't change the fact that she's refusing therapy. It's important, yes, but not a priority in this moment. So I hope that you're able to capture what's really needed in this scenario. Again, what is the root cause in this issue is basically the refusal and the fear that the patient will cause some re-injury. So we need to address that first things. Alrighty, let's move on into our next item. This is a matrix multiple choice item. It says here on day 5, the nurse evaluates the patient's status post RIF with a new thigh pain and DVT. And I want you to go back into the scenario here. I'm not going to reread this because this is the same documentation. The same thing with the laboratory tests. All right, I think we are going to have to focus on here. For the tests from day 1, day 3, and day 5, it looks like you're going to pay attention to the hemoglobin, the white blood cell count, the platelets, the creatinine level, the INR, and the activated partial thromboplastin time, and the C-reactive protein, and the result on the right leg ultrasound showing right femoral vein DVT. So your task in this test item is to complete the matrix by selecting the appropriate clinical judgment for each finding. Now, you're going to answer if the finding is improving, whether it's stable or worsening or critical. So your focus this time is to monitor the changes in day 5 data. And you're going to compare this to the prior days to determine the trends. And you need to focus on the findings that indicate significant clinical changes, and judgment should reflect on the urgency of each finding's impact. Now, what do you think you should do here? You have to evaluate that each clinical finding and make sure that you determine if it's representing the if the patient is improving or getting worse, or it's critical. Now let's go into the first finding here. It says thigh pain, 7 out of 10. Now, don't forget, I want you to go back into the trends here. 7 out of 10 pain is not just some post-op discomfort. And so we are going to put that as a critical assessment finding. We're actually dealing with the new thigh pain on day 5, which coincides with the deep vein thrombosis in the femoral vein. This is already confirmed. The pain is localized, it's acute, and associated with the swelling and warmth. And on top of that, the patient has a fever, 100.3 degrees Fahrenheit. There is that decreased oxygen saturation. And we're beginning to edge toward potential pulmonary embolism here if things progress. And DVT in this setting is not a mild issue. It is a huge red flag for embolic events, and this must be taken seriously. And that is why it earns a critical label this time. Now, what about delirium symptoms? What do you think about this one? Well, we're going to put that as worsening. And why do you think that it's not just stable or improving? Well, when you compare this to her day 3 status, she was disoriented to place and pulling at IV lines. Yes, that's concerning, but manageable on day 3. Now, when you pay attention on day 5, she's disoriented to time and person, and she's becoming more agitated to the point of climbing out of bed. That shows a clear progression in cognitive dysfunction. She's now at risk for falls, at risk for injury, and may not follow treatment instructions because of the disorientation, confusion. This is a classic sign of worsening delirium. She's further from the baseline, and she's so unsafe behaviorally. Now, let's take a look into the hemoglobin of 9.9 grams per deciliter. The answer here is worsening, of course. Looking into the lab values, that's quite obvious. Her hemoglobin has dropped from 11.5 on admission to 10.3 on day 3 and down to 9.9 on day 5. So that trend may not look alarming at first because it's kind of slowly going down. But if you're going to compare the drop here from day 1 to day 5, that's significant. All right. This is considered moderate anemia. So this is something that you're going to expect, especially for a patient that just had a surgery, especially if they're getting the heparin infusion, or let's say the enoxaparin, which is the low molecular weight heparin. So this is something that you should consider as worsening. Now, even if the patient does not have any obvious bleeding anywhere, the steady downward in the hemoglobin count is actually obvious. It suggests that there is an ongoing blood loss or an impaired recovery here. So this is not stable. This is worsening. It's not also critical, because if you're going to say critical, maybe the drop should be around 7 or let's say 6 grams per deciliter, or maybe 4, then that's going to be a different scenario. Now let's look into the CRP, or C-reactive protein, 25 milligrams per liter. This is also considered as worsening because her C-reactive protein on day 1 was 5 and went up to 10 on day 3 and 25 milligrams per liter on day 5. So that's more than a gentle upward drift. It's actually a sharp rise, and it reflects significant systemic inflammation. Now, in the context of her confirmed DVT and low-grade fever, this could be the body's response to the formation of the clots, but it also raises concern for early infection, especially since she's been having some fever. But either way, this trend is moving in the wrong direction, so we can call it stable when we don't call it critical as well. Now, for the refusal of PT, what do you think about that one? That's simple to answer, right? This is worsening. All right. She was already limited in therapy by confusion and pain on the 3rd day. Now, on day 5, she's verbally refusing, saying things like, "I'll break my hip again." So that's not just passivity, It's actually saying that she's being resistant. It reflects rising fear. There's that cognitive decline, and the pain is not adequately managed. And take note that refusal of physical therapy in a post-op elderly patient is very significant. It can cause increased immobility. It can cause more complications for DVT. It can lead to pneumonia, PE. It can also lead to slower wound healing. It can lead to loss of independence. And all these point to a decline in their function and motivation. So yes, this is worsening. All right. Now, if you marked delirium symptoms as improving or stable, that's not going to work here, because delirium is fluctuating condition, yes, but we don't guess here. On the day 3, she was confused and pulling IV lines, and day 5, she is now more disoriented and actively unsafe, and that is a clear clinical worsening. So we don't call it stable. Now, if you place thigh pain 7 out of 10, and if you labeled that as worsening instead of critical, yes, we know that the situation is worsening, but more importantly, it's connected to the DVT diagnosis. There's presence of systemic symptoms, so this makes this a potentially life-threatening issue. And I want to emphasize here that on the NCLEX, when something goes from local to systemic, or if it involves a new diagnosis, then that poses an embolic risk. It bumps up to critical. So that's my tip for you. Do not let it go. All right. Now, if you selected CRP 25 milligrams to stable, that's not accurate because it's already trending up. So it's not flatlining. And if you selected refusal of PT marked critical, it's close, but not quite. Because this is a concerning issue. It certainly is a worsening issue regarding her functional trajectory. And at this moment, it's not life-threatening in the way her DVT is. It's not critical unless it leads to a cascade like total immobility or maybe aspiration or sepsis. So the better answer here is worsening. It's trending badly, but it has not crossed that red line yet. Now we have the last item.
Before we move ahead, here's something you shouldn't miss. If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get. 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. Now, let's continue with the topic.
This is a trend type. It says here the nurse analyzes the patient's trend over 7 days post-ORIF. And the nurse's practice notes on day 7 at 6 in the morning. It states persistent thigh pain 8 out of 10, swelling, temperature 100.6 degrees Fahrenheit, blood cultures positive for MSSA, indicating surgical site infection, X-ray suggests hardware loosening, delirium improved but refuses physical therapy, orthopedic plans debridement, vancomycin started. Here we have a series of vital signs from day 1, 3, 5, and 7 for the temperature, heart rate, respiratory rate, blood pressure, oxygen saturation, and pain score. I want you to pay attention to those. And the hemoglobin levels or the other lab values from day 1, day 3, day 5, day 7. So pay attention to the big changes for the hemoglobin, white blood cell count, platelets, creatinine, international normalized ratio, activated partial thermoplastin time, and the C-reactive protein. And take a look into the study as well. I'm talking about the diagnostic study, such as the right hip X-ray and the blood cultures. And the orders, medication of vancomycin 1 gram IV every 12 hours for MSSA, heparin infusion in the therapeutic range, and the diagnostics showing X-ray right hip femur. It's to evaluate for the right hip and the femur, and the blood cultures that were done, and other orders such as prepare for surgical debridement. Now, for this test item, I want you to review the day 7 progress notes and the diagnostics to track those new findings that shift priorities. And I want you to consider how trends in the symptoms and laboratory inform action urgency. And the action should address the most pressing issue in the patient's trajectory. So here is our task. Select the most appropriate action on day 7. And these are the options. First one is continue the current plan and monitor. Prepare for surgical debridement and hardware revision. Obtain an order for an X-ray for hip dislocation. And increase haloperidol for delirium. And last option, it says adjust the heparin dose for DVT. What do you think is the answer here? The correct one is prepare for surgical debridement and hardware revision. So let's talk about this one. This is not just a mild infection or vague possible inflammation. So going back into the laboratory values, the white blood cell count is spiking 13.2 on day 7. And the blood culture is already positive for the MSSA. There's that increasing thigh pain, 8 out of 10. There's swelling. Temperature is going up, 100.6 degrees Fahrenheit. And also the X-ray suggesting hardware loosening. All right, there's still some delirium going on. And the need to start the vancomycin is already in place there. Now, on day 7, there's hard evidence of deep surgical site infection. So we have the blood culture, the white blood cell count elevation, the fever, persistent pain, their instability in the hardware in the X-ray that was done. So we've actually crossed from watch and wait into do something now territory. And here's why this is such a high stakes moment. Because when this client has a deep infection involving a hardware, it will not resolve with antibiotics alone. It will not. And the bacteria like Staphylococcus aureus, this can form biofilms on the metal implants. So these are very notorious. They're hard to treat with the medication alone. That is why surgical debridement and often hardware revision is very critical here. So this is a turning point in her plan, and that's what NCLEX wants to see. If you can recognize when monitoring is not enough and when it's time for you to escalate the intervention. Now, the rest of the options are incorrect here, such as continue the current plan and monitor. This is quite tempting because she's already on the vancomycin, right? And also on heparin. Yeah, you might possibly have selected this one. But here's the thing. We've already passed the threshold where monitoring would be safe, and she's had persistent symptoms despite the antibiotic dosage, and the imaging showed hardware instability, which suggests the infection has extended to the bone or the implant itself. And the blood cultures are also positive. And if you're going to just kind of monitor in this case, it would be delaying the intervention, which would put this patient at risk for sepsis. So think about that. It can put her at risk for osteomyelitis or even prosthesis failure. And remember that on the NCLEX, once you've got confirmed infection plus foreign body involvement, you need to act on it immediately, not just watch and monitor. Now, if you selected obtain an order for an x-ray for hip dislocation, this is one that's reflecting misdirection. Yes, there's a concern about the hip, and yes, imaging was done. But the problem is not dislocation. It's the loosening of the hardware, and this is likely due to the infection undermining the surgical fixation. Now, if she had a dislocated hip, we'd expect clinical signs like leg shortening, or maybe severe positional deformity, or maybe sudden loss of mobility, or could be intense pain with movement. But we're not seeing these signs. The hardware is not dislocated. It is unstable due to the infection. And so ordering another x-ray for the wrong reason can delay the correct intervention. So eliminate this one. Now, if you selected increase haloperidol for delirium, this feels like a comfortable option. The delirium's been an issue throughout the case, from day 3, day 5, and day 7. But here in day 7, it notes actually that delirium has improved and her mental status is stabilizing, and she's no longer climbing out of bed or pulling IV lines. So there's no reason to escalate or increase the haloperidol dose here. In fact, doing that can cause oversedation, especially that she may be heading back to the operating room, and this patient needs to be alert enough to maybe give consent or to participate in her care. So this intervention doesn't really match the current clinical priority. Now, we also have adjust the heparin dose for DVT. Why is this incorrect? Well, let's revisit the facts here. The patient is already on the therapeutic heparin infusion. Her activated partial thromboplastin time is currently at 65 seconds, which is in the therapeutic range. And her DVT is being treated appropriately. So unless there's active bleeding, or maybe an extension of the clot, or maybe a subtherapeutic activated partial thromboplastin time, there is no reason to adjust the heparin. Now, the biggest issue right now is the infection, not the clot. And choosing this option would show a failure to prioritize. The actual threat is the blood culture showing the MSSA infection, which is actually threatening her prostatic joint. So this is basically a classic NCLEX pick the escalation type of scenario. So you have been tracking those trends over several days, and even on day 3 or day 5 or day 7, on day 3, it was specific that her confusion was mild. And on day 5, DVT emerged. And now on day 7, we have an evidence of a deep hardware infection, right? And so recognizing the turning point is very critical here. And the antibiotics were started, but the infection persisted and has now been confirmed in the blood cultures, possibly going to cause implant failure. And this is not a time to slow down. You need to prepare the patient for the surgery. You need to notify the surgical team. You need to manage the pain and also to support the patient's oxygenation. And don't forget to continue the prescribed antibiotics. And most importantly, you need to act on the infection right now. So that is the end of our Q&A today. I hope that you have gained valuable insights from navigating the clinical challenges designed to mirror actual nursing practice. And I hope that you have worked through the difficult test items, and I hope that it strengthened your ability to prioritize, to act, and evaluate, which all align with the NCLEX clinical judgment measurement model. Do not forget to do that. And I want to thank you for joining me in this learning experience. I'm confident you're better equipped for the success on the NCLEX and beyond. And if you find this content helpful, Don't forget to subscribe to our YouTube channel for more NCLEX prep content. Give this video a thumbs up and share it with your study buddies. I'll see you in the next review session.